Well, good morning, everyone. It's so good to see you, and we're privileged to be following up on a really wonderful opening presentation. We all left a little bit early to come and get ready for ours, but hated to leave that because it was so interesting and wish I could have stayed. Anyway, welcome to our session. We are going to be leading a panel discussion today on health literacy related safety events, and we'll talk you through that in just a few minutes. And we hope that you will enjoy this presentation, and we also hope that you will be part of our discussion as we get going. The usual question, can everyone see my slides? And I can't. Okay, thank you. I see Mindy shaking her head and Andrea is telling me. So welcome. I'm Dr. Marianne Abrams. I'm at Nationwide Children's Hospital in Columbus, Ohio. And I'm being joined by three wonderful panelists today: Corey Gibson from Children's Wisconsin, Mindy Biebert, who's a colleague of mine here at Nationwide Children's, and Dr. Andrea Morrison, who is working, who I got to know at Children's Wisconsin and is now doing work outside of the health system in her own communication entity. So we will be talking about health literacy related safety events as a tactic to improve organizational health literacy and health outcomes. We do not have any disclosures, although some of this work was supported by a grant from the U.S. Office of Minority Health in the Department of Health and Human Services. What we want to focus on today is to describe the importance of organizational health literacy, how that relates to safety, quality, and equity. We want to illustrate a couple of different approaches to identifying, quantifying, describing, and using health literacy-related safety events in healthcare settings, and to demonstrate potential applications of how health literacy-related safety event data and findings can inform approaches to preventing serious safety events. So over this, we have roughly a 90-minute time together. During this panel discussion, we would like to use the first 2/3 of that to talk through our discussion, our presentations related to those learning objectives. I'm going to start by setting the stage, then Corey Gibson will take it from there, describe their work in Wisconsin. Mindy Biebert will describe some work that we're doing here in Columbus, and Dr. Morrison will bring a conclusion to this concluding discussion. We'll ask you to wait, hold your questions to after the presenters, and then we will open it up for questions, discussion, and more of the panel discussion as well. Each of us is going to self-introduce so that you can kind of get to know the speaker right before they present their content. And with that, I think we'll begin moving through. So again, I am an assistant professor in primary care pediatrics in the Department of Pediatrics at Nationwide Children's Hospital and the Ohio State University College of Medicine. I work a lot in health literacy, health equity, quality improvement, and medical and graduate medical education. And I'd like to just set the stage this morning by kind of describing the grounding health literacy related safety events as an approach and an important approach to addressing and improving organizational health literacy and obviously health outcomes. So just to kind of retrace our journey as a field, obviously there was a lot of work done preceding the 2004 Institute of Medicine report, a prescription to end confusion, when the Institute of Medicine Health Committee on Health Literacy first put out a defining and a groundbreaking report with a lot of really important findings and recommendations. And one of the things that struck me when I first read it, and I continue to think about a lot, is one of their very specific findings that health literacy is fundamental to quality care and specifically relates to 3 of the 6 aims of quality improvement, among which are safety, patient-centered care, and equitable treatment. So they set the stage right there, and then we continued to move through the further development of the field. And in 2012, the 10 attributes of a health-literate healthcare organization were described and detailed. And I was thinking about, how does safety and equity, how do those things interact with those 10 attributes? And as I was highlighting the ones that I thought it aligned with, I realized it aligns with all 10 attributes. Therefore, all 10 attributes are red, because there's this important component of communication and effective communication that intersects with each of those 10 attributes. A couple of years ago, when Healthy People 2030 was released, we had a little bit of a modification to the definition of personal health literacy, but even more importantly, that we had this definition of organizational health literacy, the degree to which organizations equitably enable individuals to find, understand, and use information and services to care for themselves and others, and that it be actionable. And that together, these 2 definitions constitute health literacy. But to me, it was so important that we finally had this organizational definition that created an expectation and, if you will, an obligation, that it's not up to just individuals, but that organizations and systems need to address health literacy and all those components, especially things related to equity, safety, quality. So the Joint Commission defined successful communication as taking place when providers understand and integrate the information from patients, and when people understand that information and are enabled to participate in their care. And they also noted the importance of using an interpreter when there's when language discordance, to ensure that successful communication. But by the same token, we also know that communication problems are the most common cause of medical errors, but we heretofore haven't had a robust examination and differentiation between health team member and health team member communication problems versus communication between health team members and patients and families. And as you undoubtedly know, that can lead to a range of adverse outcomes. And that risk is higher among people with limited literacy, limited health literacy, and those with language and cultural differences. The Joint Commission has a framework for looking at harm and errors, and for root cause analyses and planning interventions. But when you don't need to read this slide, but when you kind of dig into some of that framework, you see just sort of general wording, like consider the following in your response to what degree communication among participants was adequate. And talks about misunderstanding related to language and culture, handoffs, involvement of patients, families, or others, but it's sort of general. And then among the root causes, communication among teams, staff, and providers, handoffs, transitions, a little bit of a notation of language and literacy, but nothing specifically focused on this healthcare team to patient and family communication. So one of the overarching goals of Healthy People 2030 is to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. So again, this is identified as, I would say, an obligation, a call to action, and in the context that people have the right to understand what they need to take care of their health and to make choices. And therefore, we in the health system have a duty to give that information in clear, simple language, and to make sure that people understand. So I've been talking a lot about the higher level foundation and groundwork and expectations, I think. But at the end of the day, we also know that these things matter to individual people, whether it's an infant who's readmitted because of dehydration, whose parents didn't understand or remember receiving information about how to manage their feeding tube, a teenager who has diabetes, who's readmitted with elevated blood sugars because although he was taught to inject his insulin into an orange, he didn't understand how to inject it into his own body. And a patient who was readmitted with postoperative complications associated with language non-concordance that impacted their ability to understand postoperative care instructions and follow-up telephone communication. So with that as a framework, a foundation, we're going to move on and have each of our panelists, in the order that you see their photos here, present their section of our presentation. So I will hand it off to Corey Gibson and go from there. And Corey, I believe you're going to share your slides.
Yes, I will. Well, good morning, everybody, as I kind of transition and get my slides up here. Give me 1 second. And please let me know if you cannot see them. You should be able to. Perfect. All right, so I'm Corey Gibson. I am a safety specialist and a clinical nurse leader at Children's Wisconsin, and I currently work in our quality department. I'm also the current director of our Health Literacy Task Force. I have over 32 years of nursing experience as a leader, educator, and mentor, and I've really been working with just individuals, teams, and within our organization to really promote health literacy in order to improve healthcare quality, safety, and outcomes. I'm going to tell you a little bit about our journey here at Children's Wisconsin. So our health literacy journey began back in about 2009, and that was really a grassroots effort led by individuals interested in health literacy. And over time, our group really transitioned into our Health Literacy Task Force, and now it's a multidisciplinary team of over 40 team members from across our healthcare system. So our main goal and the main work that we do in our organization is really to help guide our organization to becoming that health literate organization, making it easy for children and families to navigate, understand, and use information and services to take care of their health or the health of their child. So we spent a number of years focusing on all staff training sessions on health literacy, what it is, why it's important, and what to do using our health literacy best practices. However, in like the past 5 years, we started to realize we needed to shift our focus in order to gain that additional organizational support so we could continue to evolve and make a greater impact. So we developed a key driver diagram, which focused on our health literacy organizational principles. So a key driver diagram is kind of a quality improvement plan and visual tool to help us systematically plan, structure, and identify our health literacy improvement opportunities and the strategies that we could use to move our work forward. So our global aim, and I think what most of us here at this conference are trying to do, is really to help build those health literate organizations. So that's one of the goals of our work. We looked at the 10 attributes of a health literate organization, and we used those as our secondary key drivers to help us achieve that global aim. Then we kind of took those attributes and categorized them into 4 focus areas, which would serve as our primary key drivers. This included having an engaged leadership team, having a prepared workforce, creating that health literate care environment, and really promoting that patient and family engagement piece. And then we developed interventions to help us achieve those drivers and the work to reach that aim. But with all that we hoped to accomplish, we knew we needed to engage leadership in a more meaningful way. So we began to ask ourselves, how can we garnish support for our organizational health literacy efforts? We knew we needed local data and that evidence to really support the fact that health literacy work was important and it was needed. So we began to ask ourselves, what data did we have? What were some of our organizational priorities? What areas could we actually impact some health outcomes if we started to focus on health literacy? So a family that misunderstood how to give their daughter her home medication and gives a 10-time overdose, or a mother that returns to the emergency room because she didn't know to unclamp her child's new G-tube in order to give her his nightly feedings, or a grandparent that doesn't know how to manage a life-threatening emergency when her grandson's trach gets plugged. So these stories, and thinking about the ones that Mary Ann shared at the beginning of our presentation, These are our reasons for change. So without clear communication, we're putting children and families at risk for preventable harm, adverse events, and poor experiences. So as Marianne kind of touched a little bit on earlier, ineffective communication and health literacy issues can place patients at risk for preventable harm and adverse events. And communication errors are a major factor in up to 70% of adverse events. So clear communication is really essential to ensure children and families understand health information and the care instructions we provide them. So communication research has really mainly focused on the communication between healthcare team members. And there's been little attention on the communication that actually occurs between the healthcare team and patients and families. There have been few studies which have tied safety events to a need for improvement of organizational health literacy practices. So we were actually curious what we could learn if we started looking at our own safety events and reviewing them, and if that could help be that driver for change. So we performed a health literacy related safety event review to help us describe the impact of health literate communication on patient safety and to help us identify those themes so we could actually prioritize our health literate safety practices. So we did a retrospective review looking at our safety events in our MIDAS safety event reporting system over a 9-month period. So the safety events were tagged as a health literate event by one of our safety specialists. Now, she reviewed all of our safety events within the organization. She was trained in health literacy, and she was part of our health literacy task force for over 10 years. So events were considered a health literate event when we, as an organization, did not make it easy for people to navigate, understand, or use information and services. Failure to follow the 10 attributes of a health literate organization was also considered in evaluating the events for inclusion. So we individually reviewed and quoted our health literacy related safety events. Then we met as a group and had discussion and did some final coding. Any disagreements we had, we kind of resolved by consensus. And then we did a qualitative content analysis of the events that we facilitated was by NVivo. We actually found that health literacy related safety events occurred 4 times a week. So the main themes around the safety events related to medications, discharge and transition, and health system processes. We adopted the definition of effective communication from the Joint Commission to help us in describing the events. So medication events exist when the health system, the staff, or care team does not provide or ensure effective communication with the patient, family, or caregiver when they are seeking medication information or when they're providing medication instructions. A lack of clarity in medication information or instruction can lead to difficulty understanding the medication plan, and that can result in that medication safety event. So these safety events consisted of mistakes on admission med reconciliation, providing unclear discharge medication instructions, and providing multiple conflicting instructions, as well as some immunization-related communication events. So our admission med rec errors occurred mainly due to unclear medication history taking. So the errors made included incorrect medication reconciliation, a failure to confirm dosages, carrying forward that dose in the medical record, and failing to obtain home dose from alternate sources when the medication information was not known by that family. Discharge medication instruction errors occurred when our written materials had unclear dose, unclear dosing intervals, unclear routes, or when they were missing medications. Multiple conflicting instruction errors happened, and this is when information differed between the written sources. So thinking about our after visit summary or our discharge instructions, medication labels, chemotherapy roadmaps, and medication schedules. Errors also occurred when there was a mismatch between what was given to them in written format as well as the verbal communications. Events that surrounded our immunization were the result of unclear communication about the vaccines themselves and about the clinic procedures for those vaccines. So for example, the clinic staff used jargon to describe the clinic procedure, which led to an error. In another case, there was unclear communication around informed consent and vaccine administration took place. The vaccine administrator didn't identify the correct patient. Maybe they didn't give it at the correct time, or actually did not even communicate what immunization was being given, resulting in that error. So one of the other themes was related to our health system processes. So when we have unclear communication in the healthcare system, that can lead to difficulty understanding and navigating our health system processes, and that can result in those safety events. So these events included providing unclear navigation assistance, relying on parents for specific information, and failing to address language barriers. So safety events arose when staff provided unclear navigation assistance regarding our hospital or clinic procedures, regarding home care, pharmacy services, or even just in general after visit procedures that had to happen. In these circumstances, families did not understand the process or how to obtain the needed service, the equipment, or the medication they needed. For example, for some examples, it was like families couldn't get the needed home care equipment or didn't understand how to get medication refills. In one example, we had a child who needed the blood bands for a procedure. So the parents did great. They went and had that type-in screen done the day prior. But when they arrived that day of the procedure, mom actually had the blood bands in her purse, not knowing that needed to stay on the child. When staff relied on parents for specific complex health information, or actually used parents to hand off information between teams instead of using other information systems that were in place, like our electronic health record, safety events also occurred. There was also several safety events that happened because of a failure to address language barriers. Staff often relayed verbal information without an interpreter present, or gave written information without translation. Oops. And then we have our last group of events kind of categories were around discharge and transition. So this happened when the health system, the staff, or the care team didn't provide or ensure effective communication when providing information at the time of discharge or during that transition to home. So again, a lack of clarity or being clear in our communication can lead to difficulty understanding and following that treatment plan, and then resulting in those discharge safety events. So these events included providing unclear equipment information, providing unclear teaching about their after visit needs, or providing unclear written instructions. So our unclear written information was often provided in a lot of these events, and that included missing information or having incorrect information on our after visit summaries or written handouts. Many of those were about feeding plans, including the feeding schedule and the type of formula to use. Other events included missing or wrong information about follow-up appointments, contacts, call parameters, and specific care about the disease process, or such as like wound care or how to manage things post-operatively. We also had unclear verbal teaching about care needs as one of our other sub-themes. Oftentimes, there was indication in these events that there was conflicting information, so different staff providing different verbal instructions to that family. For these events, verbal instructions often fail to provide complete details. They were missing information about follow-up and when to call. One event actually detailed that no one instructed the family on what to do with their child who went home with a pulse ox, what they were supposed to do if they started to have low pulse ox readings or had trouble breathing. Our other safety events in this category related to equipment, and these events indicated families were inadequately prepared to manage equipment at home. They weren't able to use the equipment as intended, or they were unable to troubleshoot when issues arose. For example, a child ended up having to need bilateral knee braces. But when they arrived for their therapy appointment, the therapist saw that the family didn't know how to put those braces on and actually had them on backwards. Another event involved a child with a new G-tube, and the family didn't know how to change that tube when it felt out, so it required another return visit back to that emergency room. So as part of our methodology for this work, we also considered the financial burden of these types of events. And this includes the cost for additional staff time to correct the issue, our reimbursement losses for wasted medications or services, the costs related to additional care, equipment, or rehospitalizations, and the costs incurred related to service recovery, which was needed for some of the families. Every single event we reviewed did have a financial impact, although we never quantified it in a dollar amount. So where this work led us. So reviewing and analyzing communication breakdowns related to safety events actually allowed us the opportunity to learn and identify safety improvements, as well as areas to focus on health literate communication. And you'll actually hear more about that from Dr. Andre Morrison later in this presentation. And we've also worked to improve reporting of communication health literacy related safety events in our event reporting system. We actually know that there are limitations with safety events. Our event reporting system only includes events that were known to have occurred or actually are reported. And in our past system, our communication errors had not specifically been targeted. But we recently recently moved to a new event reporting system called Origami this past September. So we've been alive about 6 weeks now. But we were actually able to build in communication questions for the event reporter, so they could comment on for all events, including questions for them to address if there was any communication issues or concerns between the healthcare team and the patient, family, or guardian. So actually having that the event reporter to actually provide that details for us. And we added some examples to help guide them and provide clarity in the system for them. So this work allowed us to build a business case to address health literacy in our organization by identifying events which involve poor communication. We will be able to prioritize our improvement efforts in order to prevent harm to our patients and families. Future opportunities include developing performance standards of health literate communication, creating a policy of health literacy best practices, and promoting reporting of communication health literacy related safety events across additional institutions for shared learning. I'm actually really excited to be able to transition our presentation over now to Dr. Mindy Vivart from Nationwide Children's as one of our first collaborative partners in identifying health literacy related safety events within their organization. So Mindy, over to you.
Hello, everyone. Can someone confirm that you can hear me okay? All right, fantastic. Oh. All right, I am super excited to share today. Please know in full disclosure that I am a relative novice to health literacy work. However, we were so inspired by the work that was happening at Children's in Wisconsin that we wanted to adapt their project and their program and implement it here. So I'm going to talk to you today about how to embed a health literacy into an established safety strategy. So I'm a nurse by training. I've been in pediatric hemonc for about 21 years. I've been throughout that time very involved in safety work and patient education. And so health literacy is something that aligns very well with my interests. I'm going to talk to you a little bit about where I work. Nationwide Children's Hospital is a freestanding academic pediatric hospital. We see a whole bunch of kids. We have 722 Central Ohio beds, including all of the community birthing hospitals, NICUs, are overseen in some way by us. We have a relationship with a small pediatric hospital in Northern Ohio and many, many regional partnerships. So pretty large, robust program. We were, back in 2009, we were the first organization to take on really trying to create a goal of zero preventable harm. When we started, we're in a program that we call Zero Hero. When we started that work, our baseline was about one serious safety event per quarter, which is quite a bit. And our record low in 2023, after having done this work for more than 10 years, is we were able to go over 500 days without a safety event. We have had one since then, but we are well up into the over 100 days since a serious safety event. So I share that information by saying that we are very skilled in the patient safety world, but we're needing ways to implement health literacy into the work that we were doing. Additionally, we have a strong program for evaluating health equity. This is just a really busy slide, not for you to read, but just to demonstrate that health equity is key to all that we do here at Nationwide Children's Hospital. And so the team that did this work is part of the Center for Clinical Excellence. That's what we call our quality and safety department. And they are responsible for oversight and support for hospital-acquired conditions, the event reporting and resolution. That's the team that's working specifically on this project. So the nurses who evaluate all the events that come through our event reporting system. And then we have another set of staff who do root cause analyses when there is an event that reaches patient harm. So really, where does health literacy fit in for us? We already talked about, we have a really robust safety culture here. We have a really robust health equity culture here. We are an academic center that is, one of the largest NIH-funded organizations. So we have a very strong evidence-based practice program. But we know that health literacy is required for best outcomes, which is really our goal. Our strategic plan is about providing best outcomes for all kids. And so we, as part of this project team, we're looking for ways to insert health literacy into the other work that we were doing. And fortunately, Dr. Andrea Morrison was coming to NCH to give a grand rounds, and we were very inspired by the work that she and Corey were doing in Wisconsin, and we decided to implement it here. So additionally, some other support that we got through this project was through the Health Literacy Learning Collaborative, which Marianne is one of the chairs of. It was a 6-month local learning collaborative. I had the pleasure of being in the first cohort. I believe they have a whole second cohort now. And what that did was really provide us, the team, with the structure, like how to set this project up, and then also the support, both from content learning, but then also from a sort of a mentorship leadership and helping us develop our project. And Dr. Morrison and Corey's article was something that they published on their work, was something that we referred to frequently as we were developing our own process. So we had really 2 aims. The first aim we have achieved. The second aim we are currently working on. We really wanted to, as our first step, was to increase the number of events that were entered into our event reporting system that were assessed for health literacy as a contributing factor. We really didn't have a process for that, so we wanted to develop a process and make sure that every single event that was entered was scrutinized for health literacy as a contributor. I'm going to share some more about how we did that in just a moment, but the follow-up aim, the second step of this project, is really looking to increase the number of events that are reported with health literacy as a contributing factor. And we are developing that system really focused on what Corey and her team are doing in Wisconsin. So for this project, we really used the DMAIC, which is a Lean Six Sigma model, interspersed with the IHI model to evaluate how to change our systems. And so as part of this first aim, we focused on defining the problem and the objective, so figuring out exactly what health literacy was going to mean to us, what our definition was going to be when we're adjudicating events, and then how were we going to measure those events so that we can eventually improve. So we're a ways away from having any actionable PDSAs or interventions to hopefully impact that, the health literacy practices within our organization, but we are well on our way for defining and measuring. So our first aim was again about evaluating and adjudicating all of our events to determine if health literacy was a contributing factor. And so this process map, all of the things in blue were steps that were already happening for our team that evaluates events. And the green boxes are steps that we added to evaluate for health literacy. So just to blow that section up a little bit in some more detail, we we adopted the model of assuming universal precautions. So assuming that everyone has a health literacy need. We have safety specialists who had extra training through the collaborative and health literacy be the first people or the first team to evaluate our events to determine if health literacy was potentially a contributing factor. And then some peer validation, which happens in 2 steps. The first being the rest of the nurses on that group. There are 3 total FTEs. They really have ongoing, in the moment discussions about the events. And then there's an adjudication team, including myself, our vice president of quality and safety, and then also one of our associate chief quality officers. So as we were developing our adjudication process, this is probably the part that was the most challenging, that required a lot of iteration. We had many discussions really looking at events in detail, and we decided that the best inclusion criteria for us was to limit the assessment to the details that were in the event report. So we kept catching ourselves sort of filling in blanks and adding to the narrative, and we realized we really needed to just stick with the facts at hand. One of the things that kept coming up as a question about the causality was this a process failure? Meaning, was there something that the hospital could have done or our organization could have done to better prepare someone from a health literacy perspective, or was it just family follow through? So for an example, is it someone who understood the discharge planning, knew where the prescription was supposed to be picked up, understood the dosing and administration, but just chose to not pick it up? That doesn't happen very often, but we did run across a couple of things that we felt like were just family follow through. And then we had thorough discussions. So each event, we did a pretty deep dive into the medical record. And eventually we came to a conclusion through consensus rules. So based on information that we learned from our colleagues in Wisconsin and then validated by our own data, communication was really sorry, my office is on a timer and it keeps going off. Communication is the category that had the most events, that feels like the space where we can intervene first when we finally get to that step. So we, as part of the collaborative that I mentioned, and with support from my friends in Wisconsin, we started with a 6-week PDSA. We screened it. So PDSA is just a small test of change. So for those of you who are not familiar with the IHI model, really you just want to try something in a small way before implementing it organization-wide. And so we chose 6 weeks worth of events. Those 3 nurses screened over 1,200 events. That's about average for the events that get reported to us any given month. And of those 1,200, the nurses identified 16 that they felt like were pretty clear health literacy related events. And as we sat down and talked through that adjudication process that I described on the last screen, we ended up with 8 where we felt pretty confident that health literacy was a pretty big factor in the causing of the event. So we know that, like, moving on to the analyzing process, we know that far more events than 8 out of 1,200 are related to health literacy. And so we realized that the system that we have in place for identifying health literacy related events is flawed. Interestingly, our friends in Wisconsin were working on some similar work at the same time. And so we are now moving on to the second aim, which is to increase the number of events that are reported with health literacy as a contributing factor. And we're doing that by, instead of the total assessment happening from the back end, the nurses who are evaluating and coding those events having to sort of rely on whatever information was listed in the narrative and note, we are now adding this question, which is very similar to the question that our friends in Wisconsin are using. We're adding this question up front to any person who is entering an event in the event reporting system. And so very, very similar. We did, we field tested this question with a lot of the leaders who do this work or in our organization, and they had a couple small edits, pardon me. But we are ready to go live with this question. We're going to leverage this work also by another team in the health literacy collaborative that was housed here in NCH. Another NCH team was working on health literacy education for all staff. And so we're really excited that our work will be coming out while, you know, health literacy is fresh in the mind of all of the employees here at NCH. As of now, we're still building. We are also going to a new event reporting system, and unfortunately that project has been delayed multiple times by the vendor. Right now, this question is not mandatory. We are advocating that it be mandatory, but as for now, it's a question that doesn't have to be answered. So this is an overall project process. Things that are in bold are things that we have already completed. The things that are not bolded are things that are still in the works. A lot of that is dependent upon the timeline of the new system project. What we are most looking forward to is identifying some clinical areas. Certainly my clinical area will volunteer to hopefully be able to identify some actionable projects that we can test in small clinical areas with PDSAs and begin to improve our organizational health literacy. So next steps, we are testing the question for accuracy. We're leveraging the organizational health literacy education rollout, and then seeking those work units to trial interventions. Lessons learned from the project that we did, and I'm out of time, so I'm going to do this pretty quickly, is we recognize that even though many of us thought we understood health literacy from an organization, we have a pretty significant gap that we needed to be intentional about trying to begin to chip away at. That, you know, unfortunately, our project timeline has been impacted by the technology timeline of another project. And one way to gain insight and energy and attention to this work is by really translating the action and by telling the why and the how. So why are we doing this, and exactly how are we doing this? It's with the information that we're sharing with clinical teams. And then leverage areas of enthusiasm. Certainly, you know, Mary Ann's group here and several other small groups within the hospital have a lot of enthusiasm for health literacy, and we plan to partner with them in this work. And then knowing that it's a marathon, not a sprint. It's been a little bit disappointing that we haven't been able to move quicker than we would have liked, but we are still chugging along. So I just in gratitude wanted to mention the team. So the top group is the patient safety team. Those are the other nurses and Dr. Julie Samora, who adjudicate with me, our friends in Wisconsin, and then the Health Literacy Learning Collaborative that Dr. Mary Ann Abrams helped co-chair. And I am really excited to hand it off to my colleague, Dr. Andrea Morrison.
Thanks, Dr. Biebert. I really enjoyed and I'm so glad that we've been able to collaborate, and very excited to talk about our work at Children's Wisconsin. Just a little bit about me. So, oh, and please let me know, I hope you can hear me okay and slides are okay. Let me know if they're not. So I am currently a pediatric emergency medicine physician. I practice clinically in a clinical institution, non-academic, called Banner Health. And I recently started my own company for healthcare consulting and research consulting in health literacy called Communicate MD. So I have had the privilege of working at Children's Wisconsin for 13 years. Corey and I were co-director of the Health Literacy Task Force for 10 of those together. I was our medical director of health literacy, which was a new established position for the last 3.5 years until I left. And the work I'm going to talk about today is from Children's Wisconsin, in case there's any questions of kind of where it is. But I'm excited to talk about how we continued our journey, because this isn't just about defining a problem, right? We need to talk about what are the things that we can do to move it forward. And this was very, the work that we did here was very iterative, looking at where did we come from? Where did we see the issues with safety events? What was the work ongoing in the institution? What were the new issues perhaps that came up? And this is all within the safety and quality realm. And Corey and I did a lot of work actually outside of just safety and quality too. But this is really focusing on what we did in safety and quality. So our journey sort of since those safety events was we started to work on health literacy performance standards, which I'll talk more about here. And in thinking how people can take the safety events and then move them and apply them to their work. And that's the same thing with the white papers, which was kind of the next step, or sort of with the performance standard. We started to develop white papers so that groups that were working on these areas, such as immunizations and medications, could use these white papers to infuse health literacy principles into their work without us necessarily even having to be at the table, though we might prefer to be there. But this is giving people tools. And the only white papers, I'm not going to talk about this any further, is that we did on immunizations and medications. And then we've worked since on project planning on medication safety, and I'll talk more about that, as well as implementation of medication safety project. And then exploring what health literacy and healthcare acquired conditions look like. So as we go forward in our journey, we grew from learning from the safety events. And by the way, these just being the tip of the iceberg of the events that are out there. So we know there are so many more, and perhaps medication is the most prominent because those are the type of events that get reported, maybe why, but also it is a really important part, and we know what a huge impact health literacy has on medication. So it does make sense that that's sort of our largest amount or largest area of our safety events. So we took this and started thinking about, okay, how can our medication teams that are working on in various teams across the institution take these and apply these? And we knew that they needed, for policy, for work that they were doing, they needed performance standards. And so please don't try to read all these. I'll talk about them a little bit more in depthly. We took performance standards from the literature. So looking at Coleman's article about prioritizing health literacy, clear communication practices, looking at those practices being more general, I shouldn't say more general, general in the health literacy principles, whereas we tried to hone them in on being medication specific when we were developing these. We also brought in kind of the voice of our health literacy task force, our nurses, our nutritionists, our doctors, our respiratory therapists that we have as part of our health literacy task force, in what they feel is very important. We kind of broke down for these performance standards the different areas of medication teaching that occur. There's general communication, but then also before the visit, during the visit, at discharge and transition, and then post-discharge. And just to give a couple of highlights, so if you look in the left column, that top one showing routinely conducting medication history taking. Now, if you look back at like the original Coleman practice, it wouldn't have medication history taking, just history taking. But including medication review with all medications and supplements present, which we know is a good principle from health literacy, that we can get a more accurate medication history when called for during regular duty. So we took and infused some of those health literacy principles that come from the literature and put those into these performance standards that are specific for medication. Routinely using action-oriented statements about medication dosing, what dose to give, when you need to give it, and how to give it. And those came again from our group, our health literacy task force individuals, and kind of what were those most important things about medications. And then if you look in the upper right, this may seem like a really long performance standard, but you'll see why. because we included a lot of principles of medication teaching that we learned from the literature. So this includes easy understand medication instructions should have dosing interval and also saying morning instead of QD, route, using a calendar, emphasizing the use of universal medication schedule, ML only dosing, how important that is for us in pediatrics, and how we dose, rounding doses for MLs when appropriate, using consistent measurement, and avoiding teaspoon and tablespoon. We didn't put the ideal, which would be to include a pictogram of a syringe, because at that time, our institution, we really weren't able to do that easily. And then routinely anticipating and addressing navigational barriers with obtaining medication and refills. So talking about how a person can help families navigate the health system as one of those performance standards that's expected. Now we can take these performance standards and then move them into policy as an institution. So as we move forward with these performance standards and talking to our medication reconciliation group and other groups, work started to come to us as they were transitioning from medication reconciliation at the time of admission to medication reconciliation at the time of discharge. And medication reconciliation essentially meaning, what are we doing for medication at the time of discharge? Looking at events, we knew discharge was a big area for error with medication, as did the hospital. And so we embarked on this work in planning our medication safety improvement and really focusing on organizational health literacy for that discharge piece of that. So as part of the planning, our global aims of our discharge med rec group for the hospital were to decrease medication harm events across the care continuum. So specifically, we wanted to do this with the aim of improving staff discharge medication instruction, and that's verbal instructions, and then aim to improve staff use of best written medication instructions. And then we wanted to do this equitably, specifically for families who have parents with low health literacy, and then other factors that are higher risk for medication misunderstanding. And so as part of this planning, we started to think about, okay, well, what does that look like from an equity perspective? What does that look like from, what are the tools that we can use to differentiate? And so we came up with these standard risk and high risk areas that both came from the literature and from our own clinical practicality and our large group of providers that were on the med rec committee, including nurses, pharmacists, physicians, to talk about what are those kind of standard risk situations and standard risk or high risk situations. And I want to think about this as a situation, not a person, right? Because they aren't only their low health literacy, they bring a lot of other things to the table. But when you combine low health literacy with perhaps speaking another language or more than 3 new medications, that puts them more in a higher risk category. And so we took things like number of medications in total over 5, the number of new medications, health literacy, language other than English, and then also included some high risk medications that people have a lot of difficulty with, and we saw a lot of safety events with, insulin for one, as an example. And then we looked at what is the standard bundle that we should be providing everyone? So what best verbal and written communication should everybody be getting? And then those in the high risk situation also will benefit from that, but they need an extra. They needed a high intensity bundle. And what does that look like? And some of these ideas come from the Marquee Implementation Manual for Medication Improvement, which is a great quality improvement manual for medication implementation at an organization wide. But the standard bundle we approached as everyone providing clear verbal medication communication training, which we could accomplish through staff and provider training. Everybody providing clear written medication communication with. And what we did was we were interested in getting Meducation, which is a program that gives pictograms for medication and prints out for families so that they have their exact medication dose, includes universal medication schedule. And also I have 20 languages on here. They've continued to expand it, it's over 40. And then the high intensity bundle could include things like intensive education at discharge in the hospital or in the clinic at transition. After visit follow-up by a pharmacist. It could include different types of materials for things that are higher risk, intensive case management, and navigators or coaches. So this was part of what our thought process was as we were going through this. This is observation data from the emergency department where we were able to complete the initial steps of this work. And so we had an observer at the time of discharge observing for core medication teaching elements and health literate teaching elements. The core medication teaching elements come from this marquee implementation manual, and then the health literate elements come from the always use teach back observation tool. And over time, this is the percent of core medication teaching elements here over time. And each of these was the implementation points that we did along the route. And you can see there's no change. So we would expect that or hope that we were able to make some improvement above with these points above the baseline, but we weren't. And I will say, this was a really difficult time in healthcare in 2021 at our hospital, a pediatric hospital. We had a huge attrition of staff nurses. We were down to 39% of our FTE at that point, and also have seen worsening quality measures across this time of our implementation in May of 2022. And so I don't want to say that this didn't work, but I think there were other factors that were involved in, perhaps this project not being as successful as it could have been. Again, this is just one unit. It's the emergency department. That is not an easy place to do this kind of work either. And if we look at our health literacy teaching elements, a baseline was about 52% were being completed, and it remained around there the entire time through the project. So as I was talking about that, you may have heard me talk about that we have worsening quality measures kind of across the board. And one area of quality that we look at are healthcare acquired conditions, or HACs, which are a part of our safety work. These groups are formed at different institutions, and cross-institutional work occurs through the Solutions for Patient Safety. And in spring 2022, we had an increasing number of HAC events and other poor quality measures. And so we, again, as through time, we just kind of iterate what is going on in our hospital and try to put our health literacy lens on it to continue to use health literacy as a tactic, or safety as a tactic for health literacy improvement. And one of the areas of HACs is called unplanned extubation. So breathing tube comes out when it's not supposed to come out. And the current HAC interventions that are planned by our group are things like keeping the head of the bed up, oral hygiene, changing the ventilator circuit when it's soiled or has a lot of fluid in there, daily discussion of readiness to extubate. We went to our health literacy task force and sat down and had some qualitative research discussions about what does this look like from a health literacy perspective and unplanned extubation? What are things that may or may not occur with a person with adequate health literacy or lower health literacy? And we talked about things like, well, a person with lower health literacy may not notify nurses at a time when they had an opportunity to notice that there was a change in the situation. Sometimes parents perceive it's not their job. They think that nurse does the nurse things, parent does the parent things. They're not actively looking for the nurse things to do. And also that having a daily discussion about this during rounds, families don't always feel like they can ask questions on the spot. They may need time to think, especially those with low health literacy may not have the right questions to ask, especially with a big group of people. So we took this idea and we looked at our actual HAC data versus health literacy, because we do the single item literacy screener in the emergency department and hospitalization on about 90% of patients. And we looked at whether a respondent said all of the time, or we'll say adequate health literacy versus had low health literacy, and found when we look at the number of ventilator days, which means how many days all added up together were all of these patients on the ventilator, and then the number of unplanned extubations, which gives you a ratio. And then we do that divided by the number of days that they were on the ventilator. It gives us a ratio of, and if we look at those with low health literacy, 0.82, and for those that had adequate health literacy, it was 0.43, with a significant difference. And this means that parents with a low health literacy have nearly twice the rate of unplanned extubations. And the important thing I think here is that now we know this. So what did we do is we went back to our health literacy task force and said, now what can we do? What are the things that you could recommend that could help a parent with low health literacy at the bedside? And that includes signage, of having representation of parent representatives on the work teams, and communication and discussion behaviors. And what does that look like from a staff training perspective? So just to put this out there, there is support for this work out there. We personally were not supported by this special emphasis notice, but this is out there, that the HARC has a special emphasis notice about interest in research and improving organizational health literacy, and using this definition of organizational health literacy. And there are definitely safety pieces of this, including healthcare quality, reducing diagnostic errors, health behaviors, patient experiences, shared decision-making, things that are very pertinent to the safety work. So I'm gonna leave you with a few key messages that I believe, and I think we all believe in doing this work, is that safety and quality can be used as tactics to improve organizational health literacy. And as I said before, this is just one of the things that Corey and I use, safety and quality. We do other work, and imagine that we work with our health equity group, for example, our patient experience, but aligning with these different areas of the organization and your organizational missions in those areas can help you infuse health literacy into your organization, and is a way to provide health equity. But really, policy is what we need. We need real change is going to need concrete policy recommendations and requirements from health systems, from accrediting bodies. The health systems need to have these policy requirements to really force the hand in making this work be done. And certification bodies need to require health literate communication as part of graduation certification requirements. And I want you to think about this. If not you, then who? Who you can start with any data that you have. You can iterate with work that's ongoing in the organization, and just infuse that health literacy organizational principles into the work that's already being done and that you are already doing at your organization. Thank you so much. I'm very excited to hand this over to Marianne for wrap up and have some discussion. And I hope there's some fantastic questions out there, so that we can have a little bit more conversation about this. And Marianne's just going to wrap us up.
Thank you very much. Give me just a second to get back to sharing a little bit of a wrap up. I hope that all of you found our panelists' discussions and what they've shared exciting, inspiring, and motivating. I'm just going to kind of do a little bit of summarizing, and then we're going to open it up for questions, discussion, and we will see where we have about 25 minutes to do that. So to summarize, I think we've all expressed that looking at health literacy related safety events clearly aligns with organizational health literacy, the 10 attributes of health literate healthcare organizations, and priorities for the health of our nation as described in Healthy People 2030. We also know more increasingly that these health literacy informed practices can be applied and used and can specifically promote things that are fundamental to healthcare, and that's health equity, safety, quality, patient and family-centered care. And that this kind of work, this kind of thinking and exploration, looking at safety data and making the case, so to speak, should be able to inform systems change to prevent and mitigate harm, the way Dr. Morrison just outlined as she wrapped up, policy to make that consistent across the the continuum of health organizations and taken into account with accreditation, funders, health professions, education and training, research to look at what it involves to integrate this into health systems, and to help build on some of that early work on identifying the return on investment or the business case, which of course is important in our health system. So with that, I don't know if you can actually see that on my my screen. I've got a little band over that, but the question here is, what questions do you have? I see a few questions in the chat. And let me just scroll up. So, Mindy, I see you responded. Carol Michaels asked, how are you seeing what insurance payers are involving health literacy? There's so much work on MSTARS and HEDIS that could be influenced, yet no formal standards or measurement to get more upstream. Good point. And Mindy, do you want to comment a little bit more on your response to Andrea Cook's comment?
Yeah, sure. I can validate that feeling, telling you that I felt the exact same way, that it's so much information, and we all work at complicated organizations, and so we just decided to pick one thing and start small and learn what we could learn from it, and then move on to the next thing. And for us, that was evaluating safety events. It doesn't have to be that, but that was information that we had readily available in our hands. So I would just recommend identifying what you have in your sphere of control, and start thinking about what you can do there.
Thank you.
In the next steps. Oh, no, you can go ahead.
No. I was multitasking. Please go ahead.
Oh, that's okay. Yeah, so for Elizabeth, in the next step slides, the first step is to test the accuracy of the screening question. I'm not sure if I missed this, but how are you going to test the accuracy of the question? So we had a lot of discussion when we were thinking about how to add a question to the event reporting system. So that screen where someone is entering the event, not the coding back end. And we had a lot of discussion about our fears that people may think they understand health literacy, but maybe they don't understand it as well as we would hope. And I can validate that by my own practice. I thought I knew a lot about health literacy, and it turns out I knew very little. And so we trialed several different questions at Children's Wisconsin. They were using a question that was based in communication, really thinking about how that family interacts with the healthcare team or the organization. So the way that we field tested it is we sent it, well, the first step that we did was touch base with our, during our safety rounds, and just asked nurses and providers and anybody that we came into contact with if how they would respond to a question. And our question is something very similar to, is it possible that this situation was impacted by how communication between the healthcare system, organization, or team and the patient, family, or caregiver? And so we got a lot of really good feedback, some ways to edit it a little bit to make it more inclusive of family structures that look different than the typical family structure. And so, yeah, field testing so far has just been in making sure that we have the verbiage correct. The real test will be whether or not, once that question is live, whether or not it actually increases our ability to capture more events. Hopefully that helped a little bit.
Thank you, Mindy. I'm not sure. I think audience members can unmute. Does someone want to do a test and just say hi or ask a question? Also, we posed a couple questions for reflection and discussion that was on the last slide, but we wanted to come back to more of a group discussion here. So I'm putting those in the chat about, and I'll invite the panelists to also comment on these questions. So what ideas do you have related to exploring, or what have you already done related to health literacy related safety events in your setting? What benefits do you see, and how might we approach a uniform approach or promote more collaboration for quantifying and describing health literacy related safety events? And then what do you see as next steps? Where could this lead? And I know that Dr. Morrison's teed some of that up, and we welcome your input as well. And there's also a lot coming in the chat. So
Marianne, if you don't mind, yeah, there was a question here, kind of a comment about that someone had said, you know, not really considering that families haven't ever seen like safety as their job, and that there may be people who don't see that, or maybe that some people do. I'm not actually sure which way to take that. I will say that what has been really fascinating when we sit down with our health literacy task force, which again really grew as a grassroots and still is. These people are not compensated for their time. This is an interest, and that is the reason that they're there. We have nurses, patient education specialists, patient experience. We have nutritionists, doctors, floor nurses to nurse managers, and of course safety, Corey and other people from safety. And we also have 2 parents that are kind of assigned from our parent volunteers, but many of the members of our group are also parents of children that have had special healthcare needs in the past or still do. And so that really helps us understand kind of that more depth of understanding of what parents with health literacy may face, because you have these parents who are, you know, nurses, for instance. They're very adept at the healthcare system, but can remember back to when their children were first diagnosed. They can think about, but think about that from that health literacy perspective, and that's where some of these ideas come from. I'll also say there was a lot of comments that I didn't even necessarily get to fit in there about culture and some of the cultural differences. So people from language services sit on our health literacy task force, and how our probably biggest cultural group is Hispanic, which is also very diverse within its own group. And but oftentimes won't feel the ability, they say they won't feel that they can speak up, or it would be disrespectful to speak up during rounds and ask a question, or to ever question anything. So there are also, you know, those cultural differences too. But I think the idea of that it's not my job is that, you know, patients and families often see, you know, certain things that are happening in the hospital. It's not up to them to say that there's an issue with the IV, right? And some of that may be because of health literacy. They didn't see that it was an issue, or they didn't know that it's something that they should be speaking up about when they do see it. And parents with higher health literacy will know and think that, oh, that's red, that doesn't look good, it looks puffy around the IV site, I'm going to call the nurse, something's wrong here. So it's a really interesting perspective to take on kind of the safety work when you think about, well, what is the actual thought process going on with families?
Yeah, I'd like to add one other thought to that as well, underscoring exactly what you said, involving patients, families, end users in early, not after things are all done and say, oh, don't you think this is great, is so important. And the Institute for Healthcare Improvement talks so much about what we can learn from them being at the table and sharing their perspectives. They're the experts, right, in what they need to know, want to know, don't know, and how we can communicate that to them. The other thought that came to mind as you were talking was we also talk a lot about a shame-free care environment, right? And what does that mean? And concretely thinking about what are the ways you as an organization can make sure it comes across clearly that you welcome and expect and want patients, families to ask questions, and what are the tools that we can put in place to do that. Sort of like the airplane where the jump pilot didn't say anything, even though he knew the plane was running out of gas, right? You've got to make it easy for people to speak up as well, whether they're part of the official health team or, well, I would argue patients' families are part of the official health team as well. All right, thank you.
And Andrea Cook had put on there the good point of using a patient family advisory council for safety to inform the approach to address parents as child safety advocate. And I think that's a really good point. And we've had one of those in the past at Children's, and I actually don't think that it exists anymore. Corey, does it? Is it still there? One of the challenges is the patient, the parent advisory group for safety. No, I don't. Yeah, I don't think it exists.
No.
The subgroup. So one of the challenges, and Corey, correct me if I'm wrong, is people have to also bring the right stuff, if you will. They have to bring the right ideas that we're asking questions about, the right problems we're asking questions about, have to bring that to the parent advisory. And they may not even be thinking about it. And so we have to change that mindset of our organization, because if people weren't using the patient safety subgroup that we had of the family advisory committee, and so it just became of disuse, I guess. I don't know if there's anything you want to add to that, Corey.
No, I think just making sure we're keeping that at the forefront, because I think they have such rich information. They're the ones that are there all the time, and they know their kids. And I think we often think in healthcare and in our counters that we're doing a good job of communicating what we want them to do, but are we really doing it in a health literate way and making sure it's really clear and telling the why behind it? All of the parents that were a part of our just conversation around the HARC work that we're doing talked about how important it is the why. Well, if you guys would have just told me the why we're doing these things, I would have been, I would have been those eagle eyes looking at those things and telling you what, hey, you forgot to hang that Foley back down, or you forgot to wash your hands when you walked in the room. So making sure we're communicating that why piece behind it, I think is really going to be important as well.
I see a question from Valerie. Was there education that needed to be done with staff on what constitutes a reportable safety event when considering events that occur outside the hospital setting, like at home? And I don't know if Mindy or Corey, you want to speak to that question? Was there education that needed to be done with staff?
Yeah. I think we definitely, everybody is part of their orientation gets told about our event reporting system. But I think we definitely need to think more broadly and better engaging our ambulatory and primary care sites and how they enter reports, because we don't get a lot of event reports from them. So I think that I saw that comment in there, and I think that's a great, how do we connect back with those teams to be putting in, because when we talk with a lot of just working in the safety department, we know, there's a lot of things that happen that's, through a telephone call, or things that folks probably staff members don't even think to enter as an event report, especially when it comes to communication. They make some assumptions like, well, the family just didn't understand, they don't think that that's a reportable thing. So I think that just spurred in my mind, I probably need to do a better job at our organization of explaining that communication piece and how we can improve that. There are things we can do, but we just need to know about those events that are happening. So thank you for that.
Yeah, I agree. I think we do a fairly decent job of getting events reported from our home care or ambulatory areas that where the event actually reached the patient or caused some temporary harm. It would be lovely to get more near misses reported so that we've got more data to respond to. We've gotten some events from home care recently about the AVS being misleading, the after visit summary being misleading in terms of the medication instructions. It didn't match up with what the prescription said on the bottle, and so that was a great example that home care called or entered the event for. But certainly, just like the rest of the project, we're sure we're missing most of them.
I think related to that too, what both of you said is that's why some of these pieces, this definition of organizational health literacy is now so important. It's everybody does need to recognize it's not, oh yeah, they just didn't understand. well, we have a duty to do that, right? So I think the more we can elevate that, emphasize that, and connect the dots between the pictures that the individual experiences of harm that Corey you described and that I included, those dots, those connect those dots between they didn't understand, but we had a responsibility to understand. I also saw a comment from, I think it's Mary Sell, about ideas for curricular content for adult education as helping them become partners in care and giving them the skills to do the kinds of things that were just described and outlined before.
Great idea.
Other
Can we
thoughts?
go back up? Can we go back up to
sure.
the question about insurance and kind of how do we get upstream of this and what are payers
Toward
doing
the
to
beginning,
involve?
wasn't it? Yeah.
Yeah. What insurance payers are involving health literacy and talking about some metrics. But I think even more importantly is how do we get upstream, right? So here we are, we're dealing with these safety events. But how is it that we can get beyond reacting to them and actually, you know, the work before they actually occur? Like, how do we get to there? I think insurance companies is an interesting idea. And value-based care is certainly should involve health literacy in, you know, things like preventing readmissions. You know, hospitals that are using value-based care within their network should really think about what are all of the aspects that we could be doing as a healthcare system. And health literacy is definitely one of those, but I just don't think that people see it as being as effective as it is. So I gave a research presentation this spring to a research group at Children's Wisconsin and talked about this asthma education initiative where we reduced readmissions from the emergency department in the hospital. And, you know, one of the senior researchers said to me, I just don't understand. Like, you actually affected outcomes with education of the families. We do education all the time, like talking about some work that he does, and it does nothing. And I'm like, well, I'll tell you what, I always have known that it is effective. And people within the health literacy world know that it is effective, but you have to do it right. You have to do it at the right time. You have to do it in the right way with the right people and the right information and the right follow-up. And I think the problem is that so many efforts in education have been undertaken by people who are not skilled in it, that there is a thought process out there that health literacy and working on you know, health education actually isn't an effective way to reduce hospital readmissions. Well, I can prove to you that it is. And so I think the hard part about it is that health literacy should be part of insurance companies, you know, and what they're expecting from health systems. You know, that's one way that we could, you know, approach this other than through policy. But I just don't think that they see the value in it in the way that we do. And is that because we're too siloed? Like, we are in our health literacy world and we're not enough, you know, showing these value-based propositions out there? And maybe that's what it is, but I'd love to hear what other people think.
I think what you just shared, Andrea, is a really wonderful something that we did not we sort of implicitly included in our list of implications and where this work could take us. I think it very much ties in with the ROI, the value, the business case. And I think it's a really important piece that we should elevate and include in those discussions. And I like you would love it if others would like to chime in on that. I know that there was a paper from one of our colleagues here at Nationwide Children's. It was a quality improvement paper where respiratory therapists in the pulmonary sections asthma outpatient clinics were all taught to use TeachBack. So the QI paper focused on what they did to reach more than 80% of the respiratory therapists using TeachBack with parent asthma education. while it wasn't a primary focus of the, if you want to call it a study, the project, during the same time frame, they had a major decrease in emergency room visits among their asthma patients. So they weren't actually measuring that. They looked at other things that could or could not have contributed to that, and other things did not change. But again, another suggestion, if you will, that it can actually influence outcomes if done right, correct? Right? And I think one of the other questions talked about that education as well.
Mhm.
Well, it's 12:58. We've got a couple other comments here about metrics, adult ed. The data are important, I think, and the stories are too. Any final thoughts? If okay. Time, financial cost. Well, I'll speak on behalf of our panel. I'll speak on behalf of myself. I want to thank the panelists. It was a great group to work together and to plan this this discussion today. And we all thank all of you for joining us and listening and thinking about this and sharing your ideas, and hopefully going forward and continuing to do so. So unless there are a few other final thoughts, I think we'll give you 1 minute to take an extra breath. Thank you all so much. Have a great day.
Thanks, everyone.